Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Sarah Brown and Dr. Michaela Kowalewski from Emplify Health about street medicine, meeting patients where they are. Let's get started. Dr. Dan.
Faisel, it's good to see you.
Great to see you. I have missed you tremendously.
I thought you had gotten too much of me when I was in Tampa.
No, not enough. You know, we talk so much over the years about the importance of the doctor-patient relationship, continuity of care and residency training programs, like things that are missing. And then all the time when we're in the clinic and in practice, we talk about meeting patients where they are, right? Like we got to meet patients where they are. But what if where they are is not a clinic? So today, I'm excited to talk about this conversation about street medicine. So we've got our two guests here. Dr. Sarah Brown, welcome.
Thank you.
Good to see you. Great to have you on the show. Also very welcome to Michaela, Dr. Michaela Kowalewski.
Hi.
And you both are in Wisconsin. I'm going to be there in a couple weeks. I'm heading up to Burlington, to Brown Lake. We have some dear family friends there, and we try to get up there around this time of year to leave the Florida heat.
Yeah, understandable.
And so let's get started with just some brief intros. So Sarah, we understand that you grew up in a large foster adoptive family. How did that shape your worldview and ultimately your career in medicine?
Yeah, I think it shaped so much of my worldview and career in medicine. So I grew up I have 27 siblings through foster care and adoption. I was one of 3 biological children in the family, and we really don't differentiate that. So that's a pretty little known fact. But I had the great privilege of having the same parents through my whole life and walking alongside my siblings as they navigated trauma and building and rebuilding lives through childhood after surviving trauma really shaped my understanding of humanity and its impacts on day-to-day life. I think I'm a humanist first, and doctor very second or third, and probably a humanist first, a mom and wife second, and then a doctor maybe. But
somewhere down the line.
That's who I am.
Wonderful. And Michaela, as an earlier in your career doctor, like what has drawn you to this work?
Yeah, I think that we have a very unique opportunity here to be exposed to this work. And that's been something that I have been interested in, being in the community and being a community member for a very long time. I grew up with my mom being a sociologist, and she did a lot of community engagement growing up. And so being in the community and meeting people where they are, it's always been an interest in mine. And having the opportunity to do that here through our program and learning from Dr. Brown and some of our other wonderful faculty, it's been amazing to continue that work.
Yeah, we talk so much in the clinic. I remember when I first started in community health, we tried to get a mobile clinic set up, and there was all this hubbub about getting it working, and we always struggled with it. When we would get it going, it was quite successful. But for you both, at what point did you realize that just a typical kind of traditional clinic care is not enough?
The origins of our mobile work were in the pandemic. Thanks to our colleague and co-founder, Sandy Brecky, who's a nurse by training, who was a population health consultant after retiring as executive director from our free clinic to work in our health system. The pandemic hit, and she went to administration and said, the only way that this is going to work, that I'll still be a consultant, is if you release me to the community. People need me. And she single-handedly for 7 months was caring for people experiencing homelessness by herself, essentially, trying to help coordinate, keeping people out of the hospitals. A couple months later, I graduated from residency, and I had, thanks to my health system, negotiated a protected 0.05 FTE for population health work. And during that summer interim between residency training and starting practice in October, we decided to try to build a street medicine program. And unlike programs that start with a mobile unit. Our program just started with 2 backpacks and a really supportive former program director who was interested in getting residents out in the community. That's Paul Kloss, who's a legend in family medicine, and me and Sandy Brecky. And we would take one resident in our private car and go out to different places where Sandy knew people were congregating. And we really built from grassroots on the relationships that she had with people experiencing homelessness in the community. All of the trust that I have had the privilege to build over the last 6 years started with her relationship and her decades of service in this community. And that, we would start in such a different way than doctor and nurse relationships usually go. Sandy would do all the talking and listening and then say, it looks like my friend here, Dr. Sarah, has a couple questions. Would it be okay if she asked a couple of those questions? And would it be okay with you if she listened to your heart and lungs? And then the resident, I would do the same thing. Would it be okay with you if my resident doctor who's finishing up training would listen too? And now Sandy's actually vice president of our health system. She doesn't get to come out with us anymore, but I still have the privilege of coming out with a family med resident and an internal medicine resident, as well as other medical learners.
Gosh, that's so beautiful. It reminds me, takes me back to residency when I was doing my labor and delivery rotation, and one of the older senior residents told me, he said, you basically got to listen and follow whatever the nurses tell you to do.
Yeah.
and you'll be fine. And that worked through labor and delivery, through NICU, but you were fortunate enough that you got to continue on with that even into your practice.
Yeah, it really,
that's a blessing.
It's such a blessing. That's true.
Yeah. And just in case he listens to this, I've got to say, Paul Kloss was one of my attendings when I was a senior resident, and then we were colleagues for a couple of years before he did other things. So Paul's been a friend of mine for many years. And when I was thinking about this, I was thinking Dr. Barnett, who was both Paul's and my mentor in residency, he would say that you could learn more from being in a patient's house for 5 minutes doing a house call than you could from seeing them in the office, monthly for 5 years. And I'm wondering, for you actually going and seeing people where they are, what are the big learnings that you're experiencing from being able to meet people in their environment on the street or in shelters or wherever you happen to see them?
Dr. Michaela, do you want to answer that first?
Sure.
I'll take us down.
I think as a resident, it is eye-opening. There's so many times when we see folks in clinic, and then we've all experienced those moments where someone drops I'm not taking my medication because of X, Y, or Z. But to see those things in real time and have the opportunity to kind of think on your feet and think about how do we overcome these barriers is a valuable skill when we're out on mobile med, but also when we're back in the clinic. And I found that my time in the community, in people's homes, or on the street when they are unhoused has made me think more about that when I'm in the clinic environment as well, because I'm constantly thinking about what does this look like when this person leaves and when they are in their typical context, which is not here in the clinic with me.
And I would completely echo that. I think practicing on mobile medicine has changed the way I practice medicine in every way. And those learnings continue every month, every year. There is not a week out on street medicine where I don't learn something that impacts my practice in clinic and my practice in other settings. We have to reshape the way we think about making a care plan. And in clinic, I now ask people, what about the plan we just made doesn't work for your life? And I pause. And that's a question I teach to my medical students in clinic and in practice. And people will tell us, they'll say, well, gosh, you just started 4 medications. I'd like to take none, or I have nowhere to store those. And street medicine exemplifies the extremes of every social determinant of health. It's where every safety net from social services fails people, right? And I think none of us would disagree with that. And so it's a environment in which you have to think strategically about how to surround someone with a care team that's effective.
Yeah, as I'm hearing you speak, I think about like our clinics are so beautiful. I look at even some of the QHCs across this country that are struggling with funding, but still the spaces are these beautiful, pristine spaces. And then we have populations of people who are living in circumstances that are not pristine. And oftentimes, we have these strict schedules and blocks, and you've got populations of people who are struggling just to get by day to day, and then we expect them to kind of get it all together for a small little window. And then when it doesn't work out, then that patient's labeled as a difficult patient, or like if they're prescribed 4 medicines and they chose not to take any of them or only take some of them, they're a non-compliant patient. Like, we're so quick to put labels on people in this perfect, near perfect clinic environment. And I feel like what you're saying is that it's just so you're really getting to see people how they are in their natural day-to-day lives. It's beautiful.
It really is beautiful and hard.
Mm-hmm.
People often will talk about how resilient someone experiencing homelessness is. And I bristle a little bit at that concept because I think about survival more than I think about resilience. I think resilience is that experience of privilege that we have as people who have resources and their basic needs met, to demonstrate that we now have resilience after what we've been through. And people living on the streets or even in emergency shelters or 24-hour shelters like the Salvation Army are surviving on an hour by hour, day by day basis. And the lessons there are profound and not to be underestimated. But I don't think about that the same way that I think about in the future. What I hope for our patients is that they have the opportunity to demonstrate their resilience for the things that they have survived.
Dr. Michaela, you've been doing this since residency. So I'd love to hear like a patient's story early on that caused you to kind of shift your view on medicine and decide in your heart that, hey, this is the way I'm going to go.
Yeah, that's hard because we've had so many wonderful and impactful experiences. The one that's coming to mind right now is actually a patient that I have the privilege of now seeing in my continuity clinic as a resident. That I first met her on street medicine. And when we first met, she was pretty hesitant to, participate in medical care, and to come to the clinic, that was a big step. And it was really through the relationships that our street medicine team had built, which was the entire team, our community health workers, our social workers, Dr. Sarah, who this patient trusted. And then I was lucky enough to go on a street medicine day with Dr. Brown, and she introduced me to this patient and said, great, you're going to follow up together in the family medicine residency clinic. And I've been seeing this patient since and seeing her growth. We see each other pretty frequently, like every 2 to 4 weeks, because there's a lot of things to tackle and she's still getting her feet under her. But every time that we see each other, I see more and more of that growth and the transition from that survival to now she's found housing and she's starting to set goals for her health. And being part of that has been amazing. And I'm just so proud of all the things that she's been able to accomplish for herself and being part of that journey. And so I frequently think about that transformation as what we all want for our patients, but it's been so humbling to be able to be a part of that. And really, I think it all just comes down to that initial trust and how do we become partners with people to help them with their health, that also allow them into a very vulnerable part of their lives.
The thing that strikes me about the conversation is you're talking about the importance. I mean, I think a lot of times physicians feel like, well, of course, patients should trust me because I've been to school for my entire life. But you're actually talking about how you build trust with the patients where they are, and then you're able to help them start making the changes in life that will make an impact on their own health. And I just think it's an interesting way to hear you all talking about that.
Yeah, I mean, from starting with 2 backpacks and a pharmacy bag, Dr. Sarah, I mean, did you ever think that it would grow into like this full unit and with a team? I mean, the team, now you've got a team of people who are earning trust, and you brought on another doctor? I mean, did you ever see it growing like this?
The short answer is no. We, we I actually never envisioned that I would be the right fit for patients experiencing homelessness. I'm passionate about reducing health disparities. I did my master's in public health, focused on community-based research, community-based program development, and I'm passionate about those things, but I have no lived experience navigating homelessness. I carry with me cultural humility, which I think is at the root of what helps us relate to other people and learn from other people and be good physicians. It has tremendously informed my practice. But no, we never imagined that we'd get a Rotary International 2-clinic room mobile unit that we're driving around places, or that we'd expand from street medicine to working in rural farming communities with farm workers and their families and other rural communities. And it's been really incredible to let the community drive what this becomes and let our learners drive what this has become. Never thought our internal medicine residents would be interested in this work, and they were reticent. Their program director, at the time they became involved a couple years ago, said, "We're doing this, and we're going to send you out." And people would tell me, "I'm so surprised I learned from you today." This is absolutely amazing.
So, what's something about street medicine that clinicians just don't understand until they actually experience it themselves?
I think one of the most consistent, surprising things I hear from our learners is, "I'm so surprised by how much I could do without all the rest of my tools." Mm-hmm. We have a handheld otoscope, we have a handheld ophthalmoscope, a stethoscope, and even now we bring handheld ultrasound, which is part of our curriculum that actually Dr. Michaela has helped develop. All of those beautifully were visions that Dr. Kloss had. We practice addiction medicine now in our practice too, which was also something he said, "I know you're going to do this." And I said, "I'm not an addictionologist. I can't do that." Every time I've told Paul Kloss I can't do something, I end up doing it. So he's a great mentor in that way. But people, I think our learners are so surprised by how much of being a doctor is not constrained by the walls. We don't need 4 walls of a clinic room. You don't need a hospital bed, though we have those resources available to us to develop a great patient-doctor relationship and to practice medicine.
I love that you were able to share some of the tools that you use. I bet you, Dr. Dan, you'd love to have a handheld ultrasound. I saw you perk up when she mentioned about the ultrasound. I know I did. But I would love for you to kind of walk through a typical day, like what you have in your pocket, where you're seeing the patients, like what are some of the common conditions that you're treating?
I can talk about that from the resident perspective. So typically we meet as a clinician team at our residency site, and then we end up driving over to meet our mobile unit, which is usually run with our community health workers. We've sometimes got social work there, some different coordinators and community members who volunteer. And so we've got our team assembled for the morning. And usually we have 2 main sites. So in the summer months, we have a church parking lot that we will park the unit in. That historically there have been a lot of unhoused folks who've congregated there. And so we are available at that site for the first part of the morning. And then we will end up going to the Salvation Army for the second part of the morning and set up our base there in the basement of the Salvation Army to see folks. In the winter, that changes a little bit because we move to the warming shelter for that first site before going to the Salvation Army. And really our community health workers do an amazing job at getting the word out, letting folks know where we're going to be. And at this point, we've built up that trust so that folks know they're going to come see Dr. Sarah, and the residents that get to work with her or our other faculty that get to go out as well. In terms of the things that we see a wide variety of things. I've seen some pretty gnarly frostbite and necrotic wounds. We've seen folks who are having heart failure exacerbations. We've seen individuals who are there to, talk about their mental health for the first time. It really is different every time, and you never know what you're going to see, which is very, I think, overwhelming sometimes a little bit as a resident. You're nervous at first, but it also is really empowering as we realize what we can accomplish just with the stethoscope and those couple of tools that we have at our disposal. So I think as a learner, one of the big takeaways that I've had is just how empowering it is to work in a team and realize what we can accomplish, kind of even with our bare bones crew.
How did you feel like your clinical decision making changes when you don't have all the conveniences, like all the access to, like the labs and imaging? Even, I mean, it sounds like you have some pretty decent guaranteed follow-up or follow-up, not guaranteed follow-up, but I just love to kind of tease that out a little bit.
Yeah, I think it is difficult to navigate. We do have the option to order labs through our system and try to tell people, go get your labs drawn at this location. We can send medications into pharmacies too. But I think one of the big things that we're learning as residents and that street med really makes us focus on is that sick or not sick. Like, is this somebody I'm seeing here in an environment where I don't have a lot of tools at my disposal quickly, or do I need to send this person to the ER? And then there's that next step of, is this person going to trust us enough to get to the emergency department? And that has been another component of this program that I love seeing. Even when I'm not on street med, sometimes when I'm in the ER as a resident, I see folks come in and on the hospitalist service, and the street med team is so well known and respected that I frequently have patients tell me, I wasn't going to come in, but I saw Dr. Sarah, I saw, Dr. So-and-so, and I them to come in. And so you see full circle moments too.
So, when you start talking about frostbite and these wounds, I mean, those are things generally when you go to the larger health system, you have wound nurses and plastic surgery, and you've got all these different tools to work on them. And I imagine some of the unhoused patients probably are very resistant to go to the hospital and go to these other places, or they don't have transportation. How do you take care of those in that setting and get people to do their dressing changes or soaks or whatever you need them to do to take care of those conditions?
Yeah, that can be different for every patient. The first thing I'd like to say about that is that we are so well connected in the rest of our jobs outside of street medicine and mobile medicine that we have relationships and trust with other departments. So I can call our wound care center and talk to a podiatrist or talk to a nurse and say, hey, I'm uploading pictures via Haiku to this patient's chart. Can you look with me? And here are the resources I have available to me to treat this. Tell me which of them I can use. And they'll say, well, I want you to have Dakins. Like, I don't have Dakins, but what about, I have this Versa-based dressing, or I have this other thing. And they'll come up with a creative solution with me. And then sometimes they'll even send someone to drive over what they actually want me to use. That's great. The next thing I'll say is our community health workers and team have really made this work possible. So our community health workers are able to meet somebody in shelter or meet someone wherever their encampment is or wherever they're staying and do dressing changes with them until they're confident doing them on their own. We still have patients who are reticent to seek surgical interventions even when it's necessary. And our podiatry team has greater faith in me as a surgeon than I do. They'll say, we'll just talk you through an isolated toe-in. And I say, I really like my license, so no thanks. I'm hearing it's challenging to get this patient in. Maybe they're told they can't come in unless it becomes an emergent EMTALA sort of situation where the patient's allowed back in the hospital because of their history. So we'll care for them until we get to that point, and then we'll be there with them through their hospitalization. We'll have community health workers present who can help people emotionally regulate, during times where it's really hard for them to be in the hospital.
You know, one thing I'm hearing you as you're speaking, it just in a small time, 20 years, the ability to be able to communicate in the way that you're communicating now. I mean, it's not that long of a time period, but it seems like a different world now. Like, of course, that makes sense that you would curbside someone, and as insane as it sounds, with the podiatrist trying to walk you through how to do an isolated toe amputation. I mean, I think about in residency how many times we've had to do things like with an extra digit when a baby is born and tying that off. None of us felt comfortable, you know, the first time that we've done these things. But if you've got someone with experience and they're there with you, I mean, I could see that working. I mean, I'd love to know some more of the point of care equipment that you have on hand. If they can't go get labs done, what are some of the vitals you can get? What are some of the point of care labs you're able to get?
Yeah. So we have a blood pressure cuff. We can get a temperature. We can do a pulse ox. We also have a point of care A1C machine, which has been great. We've got pregnancy test available. We also then have our point of care ultrasound. Do we have any other point of care labs that I'm missing?
We used to have a point of care hemoglobin, but the cartridges ended up they would expire before we would use them. So we ended up deciding that we needed to invest in that. And through our partnership with the free clinic, the patients that we care for who are uninsured, we can get labs through the free clinic, who has a partnership with both health systems in town. Sometimes there's a 1 or 2 day delay for those results, but most of our street medicine patients have insurance. And so we're able to coordinate a lot of their care through one of the 2 health systems in town. In terms of labs or x-rays that we need. Our ultrasound is considered educational by nature, so it's not considered a formal ultrasound even when we use it within the walls of the health system. And so if we find something abnormal or we need the formal evaluation, we still get a formal ultrasound. But it can be tremendously helpful to rule out DVT, to diagnose pneumonia. The ultrasounds are incredible these days.
Yeah. And sometimes to get a patient to buy in too. I heard a fellow resident was telling me about a patient they saw in street medicine, and they were able to use the point of care ultrasound to show that they were having heart failure and that they had a magnetic left ventricle. And so they were able to convince the person who otherwise didn't want to go in that maybe they should because they can see it with their own eyes that this was happening.
Gosh, you know, I feel like what you're describing, like with the clinical skills, like what's important, what clinical skills are important to be a good street medicine doctor. Like these are the skills that we all need. Like we should, we should all be practicing this way. You know, we'd be better listeners. We'd probably do better physical exams. I mean, I feel like the physical exam, in the last 15, 20 years, I'm ashamed to admit it. I mean, I have like rushed through a lot of this stuff, and I'm hearing you speaking, and I'm like, this is obviously good medicine.
Right? You can trust your ears to hear pneumonia. I'm waiting for the example of pneumonia on ultrasound that I haven't heard with my ears. But so far, a stethoscope has been diagnostic for me for pneumonia. And I think teaching residents to pop your stethoscope diaphragm right over where you're seeing pneumonia on ultrasound is a different level of learning that solidifies what I am hearing and why. And it is really powerful. It's a powerful teaching tool. It's a clinical tool, but your stethoscope's still your best friend.
Dr. Dan, what do you think Dr. Barnett, if he was alive today in 2026, would say hearing young physicians speak this way about the use of a stethoscope and the value of a physical exam?
Well, I mean, I think he would always wanted you to learn how to do the physical exam, and he would spend time teaching percussion and teaching how to do a vocal fremitus and how to actually do it before sending them down the hallway for the x-rays. And so it really was important about meeting the patients where they were. So I think he would be very supportive of this. I think he would be like a lot of the rest of us. He'd be sad that I think what the average, there's like on average more than 500,000 people unhoused every night in the U.S. And how many billionaires do we have in the U.S. that they could take a rounding error off of their personal wealth, and they could provide housing for all of these people that don't have housing. So I think he would. I think he would be sad about that as well. But he always believed in not putting the doctor on the pedestal, but putting the patient on the pedestal. Having the attitude, there you are, not here I am. And so, I mean, that when you all are describing meeting them in the community, that's exactly what I'm hearing you're doing. You're respecting them and respecting their space and respecting what's important to them. If you could change one thing about how our healthcare system cares for people experiencing homelessness or extreme vulnerability, what would it be?
I know mine. What's yours?
Oh, I don't have mine yet. You should go first.
I want to see health systems developing and being on the front lines of housing first models. I want to see those empty buildings that we know all the health systems be transformed into transitional or long-term transitional housing, and us to develop the support around that, because at the root of everyone's health problems who is navigating homelessness is housing. And if we can fix housing, we can develop all of the other pieces. But without that, we're just continuing to put Band-Aids on these open wounds.
Yours is way more specific. But I think the thing that I'm thinking about is I've had a number of patients recently talk about having to choose, paying for their meds versus being able to feed themselves. And so having some solution where folks are no longer choosing healthcare or meeting their basic necessities, which how do we accomplish that? I don't have a clear answer with my magic wand, but I would love to
maybe
take that
universal
away.
Healthcare.
Well, maybe, yeah.
We've got a rising number of young professionals who are finding common sense solutions. I'm seeing it happen in a really, just in a quite exciting way politically, but hearing you both speak, I mean, from a medical perspective, I mean, I love the attention that you're putting there, really bringing the humanity back into the doctor-patient relationship. I mean, everything you're describing is the very reasons many of us went into family medicine in the first place, right, Dr. Tim?
That's what we find in our residency program. Our mobile medicine team is popular because it reminds people of the heart of medicine.
Thank you so much. Thank you both.
You bet. Take care.
Thank you.
What are your thoughts on street medicine, meeting patients where they are? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.